Good morning, my name is Mary Lee. Today we're going to be demonstrating how to properly place an ET tubing. This is Laura, she's a paramedic, she's assisting me today. We do have gloves, we have PPE for my partner and me, which may include goggles, a mask, and a gown, and the gloves. I have a patient here who's in a sniffling position, placement with towels. We do have an OPA measured from the corner of the mouth to the tip of the ear, proper size with a mask, bridge of the nose to the chin, a BVM that's attached to high flow oxygen. It's an adult BVM. This is an adult patient. We have a section. The section is a Yanker section for we're going to look at the eyes, ears, nose, and throat and remove those items with a section. If not by the section, we do have Mag-L forceps. We can, if we're able to get it, we would get it with the Mag-L forceps, or I can use the Mag-L forceps to help insert the ET tubing into the glottic opening. I have the patient hooked up to SpO2, the monitor. We do have I have a syringe here that has 5 to 10 milliliters of air. I have the ET tube, proper size by the circumference of the little finger or the nasal area there. It does have a stylet. We'll insert the air to make sure that to show you that the cuff is working properly, which it is. I'll remove the air. I have lubrication to place on the end of the ET tubing to help guide it through. I have a proper size handle, proper size blade, which is a 3 to a 4 for an adult. It does have a light at the end, and it is the curved blade. For proper placement, we have the stethoscope. We have the capnography, which is the color capnographer, which would stay within the gold. We have the patient, again, hooked up to the monitor. So after we get the color capnography correct, I'll have my partner hook up the color capnography, looking for proper waveform and staying within 35 to 45. We have OPAs available. We have the endotracheal tubing that we've chosen is for an adult, 7 to an 8.5, depending on if it's male or female. We have a size up and a size down of the endotracheal tubings in the event that this doesn't work properly. We do have a combi tube or a king on standby in the event that it's a failed attempt. I have a stethoscope again to listen for gastric distension or looking for equal rise and fall of the chest and proper lung sounds within the patient. I think that's all. At this time, I'm going to insert the OPA, measuring from the corner of the mouth to the tip of the ear, visually inspecting the eyes, ears, nose, and throat, doing any suction that needed, using the Mag-L forceps if needed. I'll do a cross finger technique, inserting it upside down, rotating 180 degrees till it's flush with the mouth. I'll begin to ventilate my patient with the BVM EC clamp with 100% oxygen, looking for equal rise and fall of the chest, and administering the ventilations 10 to 12 breaths per minute. At this time, I'm going to ask my partner to take over ventilations, and I'll prepare to place the ET tubing. My partner's going to do the ventilations for 2 to 3 minutes. Looking at the SpO2 reader, we're going to see that it's within 100% of oxygen. I've already tested the ET tubing to ensure that the cuff is working properly with the 5 to 10 milliliters of air. You can see the equal rise and fall of the chest when my partner ventilates my patient. At this time, it's been 2 to 3 minutes. We are at 100% oxygen on the SpO2 reader. So I'm going to ask my partner to step aside. I'm going to remove the OPA. Again, visualizing the airway to ensure that we don't need to remove any debris with the Magel forceps. I'm going to place the blade of the laryngoscope left-hand side, gently moving the tongue to the right and lifting. And lifting at a 45-degree angle. I'll place the ET tubing. I'm going to remove the stylet and put 5 to 10 milliliters of air. Capnography on, manually stabilizing the ET tubing. At this time, I will take and place listen for a gastric distension, which I don't have any gastric distension. I'm going to listen for apex to apex, base to base, looking for equal rise and fall of the chest, using that suction as needed. I'm going to come and look for indecondensation within the tubing for proper placement and color change within the capnographer. I'm going to use the Thomas tube holder and secure it. And I'm going to ask my partner to get the ETCO2 capnography prepared and placed, and we're going to monitor the monitor. We're going to check the monitor for proper waveform and keep it within 35 to 45. Okay, at this time, this is finishing proper placement of the ETCO2, or ET tubing, sorry, with ETCO2 reading on the monitor. Thank you very much, Laura, and that's it.